Every year in the United States, there are 5 million catheters placed, with 50% of those not being medically necessary. Patient discomfort, increased mortality, extended hospital stays, and higher health costs are some of the downsides of catheter-associated urinary tract infections for the patients and the healthcare system. According to the Centers of Medicare and Medicaid Services, the cost of treating a single urinary tract infection caused by catheter is around $758, with an annual cost of over $340 billion in the United States. So quantitative studies demonstrate that CAUTIs can be avoided. After the education and implementation of CAUTI prevention guidelines, the prevalence of catheter-associated urinary tract infections decreased in hospitals from 2.24 per 1,000 catheter days in 2014 down to 0.70 thousand catheter days in 2016. So if you look at the chart here, you can see that prior to those guidelines, what they call them CAUTI bundles, which helps kind of direct the care for prevention with evidence-based practice, everything was above, for the most part, between 2011 all the way over to 2012. They were way up there, averaging around 2.5%. Then they came in, educated all the staff, the guidelines were implemented, and you see around the beginning of 2012, it starts dropping down to about 1.7%, and then it goes down all the way to 1%, and then it kind of stays steady, averaging around 1% throughout the year. There's a couple of peaks, but it never goes above about 1.5. So it has been proven that using these measures consistently really can decrease the incidence, and that's going to decrease the amount of deaths, complications, and longer hospital stays. So it's a win-win for the hospital. It's a win-win for the patients. Then also, like I said, the simple evidence-based approach, it could prevent about 70% of the catheter-associated urinary tract infections. And this results in a potential reduction of nearly 380,000 infections and about 9,000 deaths a year. That's huge. So catheter-associated urinary tract infections can occur through multiple mechanisms during the urinary catheterization process. This includes bacteria migrating from the urethra, rectum, and vagina, contamination from healthcare provider hands, a break in the sterile field during catheter insertion, or manual handling of the collection system. Catheterization is appropriate when the patient is critically ill, has unstable volume status, or when there is a post-bladder obstruction. Inappropriate utilization for catheters includes patients with urinary incontinence, inability to stand to void, and increased diuretic dosages. So several interventions have been proven to reduce the catheter-associated urinary tract infections. First off, staff education on catheter management, along with regular monitoring of the catheter-associated urinary tract incidences. Facility-wide programs to ensure that catheters are only inserted when necessary and removed as soon as possible. Using soap and water or perianal cleanser to clean the urethral meatus daily, and maintaining a closed urinary drainage system is recommended. And catheter-associated urinary tract infection bundles, once again, it provides hospitals the guidance for best practice in preventing these infections. Some of those protocols include identifying whether it's appropriate or not for the catheter, aseptic insertion by trained providers, approved Catheter maintenance, daily verification of the need for continuation of the catheter by the rounding physician, clear reporting and documentation for the staff providing care, and also the removal as soon as possible. So just to check everything and go through one more time, first off, always check the appropriateness, consider alternatives, obtain patient consent, wash your hands, apply sterile gloves, maintain sterility, do not break that closed system. Keep the urine bag below the bladder level and off the floor. Do not hook it on the rail as that could become dislodged. Ensure that there's free urine flow. There's no kinks or loops in the tubing. Use clean, patient-designated container when emptying the bag, and do not let the drainage spout touch the side of the container. Verify the need for Foley continuation daily with the physician rounding. Document and report Foley use to oncoming shifts. So if you follow these guidelines, you can prevent infections and unnecessary complications to your patients, and also save your hospital money, as anything that occurs in the hospital in this way is not covered by Medicaid or Medicare. Thank you so much for listening to my presentation.